Welcome, everyone, to Vet NeuroJar, the podcast dedicated to exploring the intricate world of veterinary neurology and the challenges faced by our equine companions. Today, we delve into a perplexing condition that can arise following anesthesia in horses, post-anesthetic myopathy, or PM. We will be drawing on a recent study that sheds light on a unique and severe form of this condition seen in warm-blood horses. Anesthesia, while generally safe for horses, isn't without its risks. Most horses recover smoothly, standing within 30 to 60 minutes after the procedure. However, a small percentage of horses, between 1 and 2%, may develop post-anesthetic myopathy. This condition carries a significant mortality rate, ranging from 16 to 20%. This study focuses on 7 warm-blood horses that developed severe rhabdomyolysis, a breakdown of muscle tissue, despite appearing stable during anesthesia. These horses, a group of 6 geldings and 1 mare, had a median age of 9 years and a median weight of 615 kilograms. These warm-blood horses, with no prior history of muscle issues, experienced significant complications after undergoing general anesthesia. Before their procedures, 5 of the 7 horses were in regular work, while the activity level of the remaining 2 was not known. The troubling aspect of these cases was the prolonged recovery time. Some horses struggled to stand at all, leading to euthanasia in 3 instances due to persistent recumbency. In 4 cases, rhabdomyolysis recurred between 5 and 11 days after the initial anesthesia, with only 1 horse surviving this recurrence. Clinically, these horses exhibited muscle stiffness, pain, and sweating, struggling to remain standing. As the condition progressed, their serum creatine kinase activity, a marker of muscle damage, and lactate concentrations, indicative of metabolic stress, increased dramatically. To understand the significance of these findings, I spoke with a guest with knowledge in equine neuromuscular disorders.
Post-anesthetic myopathy is a complex condition with various contributing factors. Heavy body weight, specific body positions during anesthesia, reduced mean arterial pressure, increased intracompartmental muscle pressure, and venous stasis can all lead to ischemia and muscle degeneration. When we examine the muscle tissue under a microscope, we often see hyaline necrosis of muscle fibers, infiltration of macrophages into the fragmented fibers, and, in some draft breeds, the presence of amylase-resistant polysaccharide.
The study revealed key histopathological findings in these warm-blood horses. At necropsy, 5 of the 7 horses showed complete glycogen depletion, while 6 of the 7 exhibited acute myodegeneration. Furthermore, chronic active myodegeneration was observed in the skeletal muscle samples. Even in the surviving horse, a muscle biopsy taken 14 days post-anesthesia showed rare glycogen-depleted fibers. Let's delve deeper into the individual cases to better understand the nuances of this condition. Horse 1, a 5-year-old Oldenburg gelding, underwent anesthesia for a cervical computed tomography scan and radiographic myelogram. Despite the imaging revealing only mild degenerative changes, the horse experienced a prolonged recovery. The day after anesthesia, stiffness was apparent, accompanied by increased serum aspartate transaminase and creatine kinase activity. The horse's condition deteriorated despite treatment, leading to recumbency and euthanasia on day 7. Necropsy revealed severe muscle damage, and muscle histopathology confirmed severe subacute bilateral skeletal myocyte necrosis and complete glycogen depletion. Horse 2, a 15-year-old Hanoverian gelding, was anesthetized for exploratory ciliotomy due to colic. The surgery revealed a left dorsal displacement of the colon. Although the anesthesia was seemingly uneventful, the horse took 4.5 hours to stand, and serum creatine kinase activity increased. Pigmenturia developed, and despite initial improvements, muscle fasciculations and pigmenturia recurred. The horse eventually improved with treatment, including dantrolene, and was discharged. Muscle biopsy showed no evident myodegeneration or regeneration. Horse 3, a 4-year-old Holsteiner gelding, presented with colic and underwent surgery for a segmental volvulus. The horse initially stood with assistance but was unable to remain standing. Despite treatment, the horse's condition worsened, leading to euthanasia on day 11. Muscle histopathology revealed acute myonecrosis and chronic myodegeneration with glycogen depletion. Horse 4, a 7-year-old warm-blood gelding, was anesthetized for injection of biologic agents into the right bicipital bursa due to lameness. The horse had difficulty standing after the procedure and developed pigmenturia and firm muscles. Despite treatment, the horse became recumbent and was euthanized on day 10. Necropsy showed severe muscle pallor, and histopathology confirmed acute necrosis and chronic muscle degeneration with complete glycogen depletion. Horse 5, an 11-year-old Hanoverian mare, underwent surgery for osteochondral fragments. Despite an uneventful anesthesia, the mare never stood, even with assistance. The horse exhibited increased creatine kinase activity, hypoxemia, azotemia, and hyperlactatemia. Due to muscle fasciculations and lack of coordination, the horse was euthanized. Muscle histopathology revealed acute myodegeneration and complete glycogen depletion. Horse 6, an 18-year-old warmblood gelding, was presented for colic. A jejunal resection was performed. The horse required sling assistance to stand and later developed colic signs, becoming recumbent. Euthanasia was elected. Histopathology showed acute myonecrosis and glycogen depletion in degenerating fibers. Horse 7, a 10-year-old Oldenburg gelding, presented for colic and underwent surgery for a large colon torsion. 12 hours post-anesthesia, severe rhabdomyolysis developed, leading to recumbency and euthanasia. Muscle biopsy revealed acute myonecrosis and complete glycogen depletion. What are the expert thoughts on these cases?
These cases highlight a severe form of generalized post-anesthetic myopathy in warm-blood horses that lack the typical risk factors. What's particularly striking is that these horses either couldn't stand or took a very long time to do so, despite remaining stable during anesthesia. Their creatine kinase activity and blood lactate concentrations were normal before surgery, but rose dramatically as the myopathy developed. The recurrence of rhabdomyolysis in some horses is also concerning. I agree with the study authors that this could reflect a disruption in muscle homeostasis caused by hypoxia or reperfusion injury, a hypermetabolic event, and ongoing oxidative stress.
The study authors propose several factors that may contribute to this severe form of post-anesthetic myopathy in warm-blood horses. While increased body weight has been linked to poor anesthetic recovery, its specific association with post-anesthetic myopathy is less clear. Body position, particularly lateral recumbency, can also increase the risk. However, in this study, the rhabdomyolysis was generalized, and most horses were positioned in dorsal recumbency, suggesting that positioning alone wasn't the primary cause. Prolonged anesthesia, hypoxemia, ischemia, and low mean arterial pressure are also proposed risk factors. However, the anesthetic times in this study were within published durations for similar procedures, making prolonged anesthesia an unlikely contributor. One potential key factor is the triggering of a hypermetabolic event during recovery. While mild increases in lactate are common after anesthesia, the levels seen in these cases were exceptionally high, suggesting profound anaerobic glycolysis.
Skeletal muscles, especially the fast-twitch fibers abundant in equine locomotor muscles, are highly susceptible to ischemia-reperfusion injury. This injury could contribute to the metabolic changes observed. Glycogen depletion, hindering the muscle's ability to produce sufficient energy, is a critical determinant of skeletal muscle ischemic necrosis.
The authors also considered malignant hyperthermia, a condition caused by mutations in the sarcoplasmic reticulum calcium release channel. However, genetic testing was negative in one horse, and increases in body temperature were not noted, making malignant hyperthermia less likely. Oxidative stress, resulting from reperfusion injury, could also play a role. Prolonged oxidative stress due to antioxidant deficiencies might alter the function of the sarcoplasmic reticulum calcium release channel, increasing its sensitivity. Beta-adrenergic hormones, potentially triggered by stress, could also contribute to excessive calcium release and rhabdomyolysis. The possibility of an underlying predisposing myopathy in these warm-blood horses was also explored. While one horse showed histopathologic changes suggestive of recurrent exertional rhabdomyolysis, the remaining cases had no evidence of chronic myopathy. The author suggests that an unknown genetic predisposition to post-anesthetic myopathy may exist in warm-blood breeds. So what can veterinarians do to mitigate these risks?
Pain management and intravenous fluids are crucial in managing rhabdomyolysis. If oxidative stress is involved, antioxidants like dimethyl sulfoxide and vitamin E may be beneficial. Dantrolene, which impedes calcium release from the sarcoplasmic reticulum, could also be a valuable therapeutic. Monitoring muscle enzyme activity and lactate levels closely after anesthesia is essential for early intervention.
The study authors emphasize the importance of careful monitoring and management during the peri-anesthetic period. They recommend maintaining normal blood pressure, proper positioning, and adequate padding during anesthesia. In the post-anesthetic period, clinical signs, muscle enzyme activity, and lactate levels should be closely monitored. They also suggest monitoring for up to 2 weeks to detect delayed onset of rhabdomyolysis and recommend prompt initiation of dantrolene therapy if signs develop. This study, while limited by its small sample size and retrospective nature, sheds light on a concerning trend of severe post-anesthetic myopathy in warm blood horses. It underscores the need for heightened awareness, careful monitoring, and prompt intervention to improve outcomes in these cases. Further research is warranted to explore the potential genetic predispositions and underlying mechanisms involved in this condition. That concludes our episode for today. Thank you for joining us as we explored the complexities of post-anesthetic myopathy in warm blood horses. From Vet Neurojar, keep those minds inspired, hearts light, and tails wagging.